like to welcome you on behalf of the Royal Society of Canada. Canada's National Academy, the Royal Society of Canada, recognizes Canada's leading intellectuals, scholars, researchers, and artists, and mobilizes them in open discussion and debate to advance knowledge, encourage integrated interdisciplinary understanding, and address issues that are critical to Canada and Canadians. The RSC is hosting this event, and their offices are located on the traditional unceded territory of the Algonquin Nation. From coast to coast to coast, we are grateful to acknowledge the ancestral and unceded territory of the Inuit, First Nations, and Métis peoples, and recognize the dozens of languages and cultures Indigenous peoples have brought that enrich what many call Turtle Island. Today, we're going to ask 4 questions following Health Canada, approval of the COVID-19 vaccine for children aged 5 to 11. What have we learned from previous and current childhood vaccination programs? What's new about this vaccine? Are there acceptable reasons to refuse it? And what does the vaccination of kids against COVID-19 enable for schools and for communities? I'm your moderator today. My name is Shannon Proudfoot, and I'm the Bureau Chief for Maclean's here in Ottawa. I'm going to introduce our panelists as well now. We have Laurence Monet, Professor of History and Director of the Center for Asian Studies at the Université de Montréal. Upton Allen, Professor in the Department of Paediatrics and Institute of Health Policy Management and Evaluation at the Hospital for Sick Children, University of Toronto. Colleen Flood, University Research Chair in Health, Law, and Policy, and Director of the University of Ottawa Center for Health Law, Policy, and Ethics. Danièle Behn-Smith, Deputy Provincial Health Officer, Indigenous Health in BC's Office of the Provincial Health Officer. We've invited each one of our panelists to speak to one of our questions. And following this, we will open this up to questions from the audience. You can submit them in the chat if you have some questions. You can certainly do that as you're thinking of it while the panelists are speaking, or afterwards when we go on to the Q&A portion. Should you wish to join the conversation online or to learn more about RSC events or policy briefings, you can follow the RSC on Twitter at RSC The Academies. The handle has also been included in the PowerPoint slides today. Now I'm going to start with the questions to our panelists. I'm going to start with Dr. Monet. What have we learned from previous and current childhood vaccination programs?
Thank you, Shannon. So I'm going to talk in French, but slides are in English. And so feel free to ask questions in English at the end. J'aimerais commencer d'abord pour vous remercier d'être présent aujourd'hui à cette rencontre et par dire, parce que je pense que c'est important de toujours le rappeler, la vaccination de masse sous la forme de vaccination de routine ou de campagne massive de vaccination est au cœur de la santé publique moderne et de la protection de la santé des enfants depuis au moins 2 siècles. Mais cette histoire qui l'inclut n'est pas une histoire très linéaire. Et c'est sur cet aspect-là que j'aimerais revenir pour vous présenter quelques éléments de contexte pour mieux saisir comment on peut aborder la campagne qui s'annonce. Les enfants ont toujours été au cœur des initiatives de vaccination. Individuellement, comme Joseph Meister, que Pasteur va vacciner contre la rage au XIXe siècle, et aussi collectivement. Individuellement et collectivement comme sujet d'expérimentation dans l'objectif d'être sauvé d'une maladie grave ou mortelle, et puis comme cible prioritaire de campagne de vaccination et de vaccination de routine depuis le tournant du XIXe siècle, avec le cas bien connu, je l'imagine de tous, de la vaccination mondiale contre la variole, qui est, je vous le rappelle, la seule maladie éradiquée à ce jour. Alors, protéger les enfants des maladies infectieuses, de maladies souvent d'ailleurs qu'on rencontre dans l'enfance, ce n'est pas le cas de tous les vaccins. Tous les vaccins ne sont pas des vaccins infantiles, mais dès le XIXe siècle, la vaccination sert à protéger essentiellement les très jeunes enfants, ce qui pose inévitablement des questions particulières. Protéger des enfants qui sont de petits êtres fragiles, qui ne donnent pas leur consentement à une procédure médicale, ce sont des choses qui apparaissent déjà au XIXe siècle. Et elles apparaissent d'autant plus qu'on se pose des questions sur les vaccins dont on dispose, qui sont des questions qu'on retrouve encore aujourd'hui sous d'autres formes, des anxiétés par rapport à la toxicité, des anxiétés par rapport à l'impureté, la procédure vaccinale engageant l'inoculation avec la variole de la maladie, d'une forme de la maladie qui vient de la vache. Vous avez là une caricature qui montre en partie les angoisses associées à ça. Anxiété aussi par rapport à l'inefficacité de la procédure à l'échelle individuelle et collective. Et pour autant, avec la fin du XIXe siècle, la vaccination contre la variole est la première vaccination, et en fait la seule à l'époque, à devenir l'objet de textes de loi pour l'imposer dans un certain nombre d'espaces, dans un certain nombre de pays, dont le Canada, en fait, les provinces canadiennes qui ont déjà le mandat de s'occuper de santé publique à l'époque. De ce fait-là, on voit surgir un certain nombre de manifestations, pour certaines d'entre elles très violentes, souvent dans des contextes politiques ou économiques qui les poussent. En particulier là, c'est une manifestation contre l'obligation vaccinale qui se tient à Toronto en 1918. Et qu'est-ce qu'on réclame dans cette manifestation assez imposante? L'abandon de l'obligation vaccinale, mais dans un contexte très, très particulier. Ce contexte est le suivant, c'est la fin de la guerre, on est en pandémie de grippe et surtout, on part du principe que l'obligation vaccinale est une invention allemande et qu'il n'est absolument pas question d'importer cette façon de faire sur le sol canadien. Et pourtant, c'est pour ça que généralement on voit l'histoire de la vaccination infantile comme quelque chose d'assez linéaire, une construction qui est la construction d'un succès mondial. Dans les années 50, 60, un vaccin semble vouloir faire la différence et limiter les oppositions, limiter les angoisses. Et il s'agit du vaccin contre la polio. Pourquoi ce vaccin va avoir tellement de succès et apparemment être le plus consensuel des vaccins au XXe siècle? Eh bien parce qu'il s'agit d'éviter une maladie qui fait d'énormes dégâts, en particulier en Occident, mais pas seulement, qui entraîne la mort de nombreux enfants et surtout qui entraîne des handicaps chez les enfants nord-américains, européens, en masse. Et cette angoisse du handicap et du décès de l'enfant va jouer un rôle absolument énorme dans l'acceptation de ce vaccin dont on va se servir, là en l'occurrence en quelques années seulement, dans des programmes, des campagnes massives de vaccination soumises à l'obligation vaccinale, puis la mise en place très très rapidement de vaccinations de routine contre la polio, jusqu'à mobiliser des stars de l'époque, et en particulier Elvis Presley en 1956, qui va jusqu'à se faire vacciner à la télévision alors qu'il est adulte pour promouvoir la vaccination des enfants. Et pour autant, dès les années 70-80, le nombre de vaccinations augmente sur le plan quantitatif. On vaccine de plus en plus les enfants du monde et en particulier les enfants canadiens. Sur le plan qualitatif aussi, on a de plus en plus de vaccins à notre disposition, en particulier un vaccin contre la rougeole et la rubéole et les oreillons, qui va devenir le fameux MMA ou RRO ou ROR. Et il s'avère que dans ces circonstances de densification de l'offre vaccinale, eh bien, on voit ressurgir un certain nombre d'oppositions, un certain nombre de comportements réfractaires. Pourquoi à l'époque, et c'est là où le travail de l'historien est intéressant pour saisir certains éléments du refus ou de l'hésitation vaccinale aujourd'hui dans le contexte de la Covid. D'abord, eh bien, avec la polio, on s'est dit, on n'a plus besoin d'éduquer les parents aux bienfaits de la vaccination. Ils savent que la vaccination est une bonne chose. Et donc, l'éducation aux bienfaits de la vaccination a commencé à disparaître des écoles, des cabinets pédiatriques, de la publicité. En deuxième lieu, on est à une époque où les sciences que sont la vaccinologie et l'immunologie sont en pleine expansion, suscitant un certain nombre de questionnements. Et en particulier, c'est à cette époque-là qu'on voit surgir des réflexions de parents qui disent « Ah non, moi, je ne veux pas tant de vaccins dans l'organisme de mon enfant. J'ai peur qu'il y ait une saturation de son système immunitaire. » C'est à partir de cette époque-là qu'on entend parler de ça. Et puis, un autre élément très important, c'est qu'à partir des années 70 et 80, beaucoup de professionnels de santé, beaucoup de pédiatres et beaucoup de parents sont persuadés qu'on est à la fin des maladies infectieuses, qu'on est entré dans une autre ère. L'ère des maladies chroniques chez les adultes ou dégénératives, l'ère de l'asthme, des allergies et bientôt de l'autisme chez les enfants. Et c'est dans ces circonstances-là que la vaccination infantile massive va devenir ce qu'on peut appeler une procédure contestée, une technologie qui est l'objet de critiques de plus en plus virulentes à nouveau. Et au final, on se retrouve à la veille de la Covid. Quand je dis la veille, je parle du 21e siècle, dans une situation qui paraît extrêmement paradoxale à bien des égards. On a une force dans la démarche vaccinale mondiale qui est absolument monumentale, qui passe par des statistiques très révélatrices d'un effort à la fois des organismes internationaux, des gouvernements, pour vacciner toujours plus les enfants du monde contre la rougeole, contre la polio, contre d'autres maladies. Mais en même temps, on est à une époque, et on en voit les relents aujourd'hui dans le contexte de la pandémie actuelle, où les questions d'accessibilité, d'équité à l'accès aux soins et pas juste à la vaccination, les problèmes qu'on voit ressurgir aujourd'hui de ce qu'on appelle l'apartheid vaccinal, où certaines personnes ont accès, d'autres pas, viennent densifier, complexifier, rendre extrêmement difficile le consensus autour de la vaccination systématique des enfants. Pour le dire autrement, la vaccination des enfants ne peut pas, ne doit pas être une solution simple. Et je finirai sur quelques questions. Finalement, dans ces circonstances actuelles, où la vaccination est devenue ou devrait devenir la solution à tout, 3 questions se posent quand on est historien et qu'on travaille sur les maladies infectieuses et la vaccination. Pourquoi, et elle paraît simple cette question, pourquoi vacciner les enfants? Qu'est-ce que veut dire aller chercher l'immunité du troupeau, l'immunité du groupe dans les circonstances actuelles, et quelle est la place de la population infantile? Et enfin, et ça c'est quelque chose qu'on voit surgir très régulièrement du côté des gens réfractaires à la vaccination, dans les manifestations qu'on qualifie souvent d'anti-vax et qui ne le sont pas forcément. Est-ce qu'on peut envisager une gestion de la pandémie que nous subissons tous depuis près de 2 ans, autrement que par le seul biais de la vaccination systématique, dont celle des enfants? Thank you very much.
Thank you for that. I'm going to turn to Dr. Allen next. And the question I'm hoping you'll address for us is, what is new about this vaccine?
Thank you so much. And it's a pleasure to be here today. I sincerely appreciate the opportunity to speak with you all. And I'll focus on what's new about the vaccines, essentially targeting the Pfizer mRNA vaccines. And the outline of what I'll address is shown on the next slide, where I will focus in a quick hit fashion on the major benefits versus risks of vaccination. The focus on information from clinical trials, surveillance data, what's new about the vaccine that is being used in children at the moment, and then the question of long-term side effects. I will address those. Vaccines for children and for anyone is always a difficult topic, but the important point really is that one focuses on benefits versus risks, and one moves in a direction that is seen as being beneficial to the individual and to society. And overall, the benefits of vaccinating children with COVID vaccines, I believe, and most experts, if not all, do believe that benefits far outweigh risks. What are the major benefits versus risks? On the benefit side of the equation, we see 2 categories of potential gain. Number one is the impact on individual illness prevention. And the second is impact on disease transmission. In the first category is acute illness, for example. We know that children overwhelmingly get mild COVID when they do get mild COVID, but some do have severe COVID with devastating outcomes. And as more and more individuals get infected, we will see increasing numbers of children who have severe outcomes from COVID. So they don't all get mild illness. Then there's the multi-system inflammatory syndrome in children, which can be a devastating outcome with mortality. Fortunately, it is still rare, but does create challenges when children do get this entity. And then there's long COVID, which is more clearly documented among adults, but does occur in children, and perhaps might be more frequent in children than has been detected so far, simply because among adults, signal detection is easier than young children. For example, an adult who's had COVID might speak of brain fog. How do you assess brain fog in a 3-year-old or a 5-year-old? So there may be an issue with signal detection in young children. It is an issue. And long COVID may result from COVID at a mild end, as well as a moderate or severe end. So regardless of a severe illness, one may have long-term sequelae. Then there's the impact on disease transmission, schools, homes, and communities. Now, I won't dwell on this because I believe one of our panelists will focus on this in more detail. But we recognize that there are risks. The question is, what are the most relevant risks? The one signal that we see appearing with the COVID vaccines, the mRNA vaccines, relates to pericarditis, myocarditis, and I will address that in subsequent slides. And so what information do we have from clinical trials in children? What's new? With respect to safety, to date, the Pfizer vaccine, it's the one that is available in Canada now for children, was studied in over 3,000 children, 5 to 11 years of age. No serious side effects have been detected to date, but monitoring is ongoing and we have to keep assessing information as it becomes available. The side effects that have been seen when different doses of the Pfizer mRNA vaccine were given to children. And here we have 3 doses, 10 micrograms, 20 micrograms, and 30 micrograms. And the bottom line is that the 10 microgram dose, which is the dose that is being recommended for use in children now, was found to be associated with less local reactions in terms of redness, swelling, and to some extent, pain at the injection site. And so the 10 microgram was, in terms of local reactions, was associated with fewer of these events. And so a similar trend where the smaller dose, 10 micrograms, was associated with fewer systemic side effects. And so overall then, in summary, we have the 30 micrograms that adults got. We have the 10 micrograms that's now being proposed for kids, and the 10 microgram was seen to be a safer dosing when one looks at local as well as systemic side effects. The question is, well, what sort of data have we seen emerge from surveillance and also from the literature? And again, trying to look at signals associated with safety. There's no question that myocarditis, pericarditis have emerged as issues. And in that regard, the myocarditis, pericarditis issue was seen more frequently following the second dose of the mRNA vaccine. Using data from Ontario, we noted that the Pfizer vaccine was associated with fewer numbers of pericarditis, myocarditis compared with the Moderna vaccine. And it was thought to be possibly related to the dose of the mRNA vaccine. So as a result of that, coupled with data that are emerging from the literature and from surveillance, the dosing of the Pfizer vaccine of 10 micrograms was felt to be likely to be associated with lower rates of pericarditis, myocarditis, if such events will occur in the kids who are younger. And the reason for this is that the initial surveillance data using the mRNA vaccine for older individuals, like older teenagers, young adults, indicated that individuals, for example, who were 16 to 19 years of age had higher rates of pericarditis, myocarditis compared with those 12 to 15. And essentially, what happens is that as you get younger, the pericarditis, myocarditis signal decreases. So you get lower rates of pericarditis, myocarditis. That's number one, coupled with the lower dose, we feel will result in fewer cases of pericarditis, myocarditis in the younger age group. It shows the rates of myocarditis over different age bands for Finland. And this is pretty similar to data that have been generated by ICES in Ontario. And essentially, what it is showing is that prior to COVID, as you get younger, the rates of myocarditis fall. So an 8-year-old would be having lower rates of myocarditis compared with a 15-year-old. It is felt that this pattern will actually mirror what has been seen with the COVID mRNA vaccines so far, in terms of young adults having higher rates than older teenagers having higher rates than younger teenagers. And so the prepubertal children would be expected to have the lowest rates of myocarditis if they do occur. So in summary then, what's new, the myocarditis signal, pericarditis, that signal is new. It is an issue, but fortunately, for two reasons, it is expected to be very rare if it does occur in the prepubertal children. One, because that group rarely gets myocarditis to begin with. And number two, the dose of the vaccine that is being used is a third of what was being used in adults. It's 10 micrograms. So what are the long-term side effects? I know this has come up a lot. Now, we've just talked about acute side effects, the pericarditis, the inflammation of the coverings of the heart, the myocarditis, inflammation of the heart muscle. Well, what about long-term side effects? And I know it's often very difficult for the public to appreciate, but the reality is that when vaccines produce side effects, they tend to occur within hours, within days, within months, within weeks, and at the most a couple of months, not in terms of several months or years later. It just doesn't happen. In fact, in the history of vaccinology, it's really hard to think of a scenario where a vaccine produced a side effect that was not identified within the first few days or first few weeks. Maybe 60 days might be the maximum. And so it's very unlikely then that the mRNA vaccines or any of the vaccines that have been used will result in side effects that emerge in the future. We recognize that that it can be challenging for families, and so it's important for families to connect with their trusted healthcare providers to discuss issues around short-term and long-term side effects, or the absence of the latter. Now, what's different about the pediatric vaccines? The active ingredient, the mRNA, is similar to the adult product. The big difference is that the dose is smaller. So it's 10 micrograms and not 30 micrograms. The formulation is a different formulation in terms of the what's referred to as the buffer, the stabilizers, and the solutions that are used in the vaccine to keep them well stable and well balanced. But the ingredients are very easy to find online. Companies have to be very transparent with what's in the vaccines. The substances that are in the vaccines are things that are used in various types of medicines. Is really nothing new. And the way to think of it is the mRNA along with the lipids, along with salt and sugar. And I often think about it almost like, to use an analogy, like a chocolate coated raisin, where the raisin is covered by a chocolate coating of sugar and fat. And essentially, that's what the mRNA vaccines are all about in terms of the way they're made up. And so a key important difference between the vaccines from the point of view of just, being aware of what is what, the adult vaccine had a purple top, whereas the pediatric vaccine has an orange top. It's important not to mix up the two. They're very different in terms of the formulation and the dosing. But if your child is in line and the vaccine comes out of a purple top, then you know that's wrong. So just to leave you with that important difference between the pediatric formulation and the currently available adult product. And so with that, I will stop and thank you very much for the opportunity to speak with you today.
Thank you for that, Dr. Allen. Next, I'm going to go to Dr. Flood, and she is going to address whether there are acceptable reasons to refuse the vaccine and whether the government can mandate vaccines for children.
Thanks very much, Shannon, and it's such a pleasure to be here, and thank you to the two previous wonderful speakers. I thought I would ask this question because I think at some point we are going to have to address it, and I thought it would be helpful to perhaps lay out some of the thinking about the way that courts will approach this kind of question. So whether in the future governments might mandate COVID-19 vaccination for school attendance. So the kinds of claims that are made against mandatory vaccinations, or for that matter, against requirements for proof of vaccination, and these two things are related some, are grounded in, if we're looking at the Charter of Rights and Freedoms or sometimes other human rights legislation, they're grounded in claims to religion and or conscience rights in Section 2, to mobility rights, so our ability to cross borders, for example, in Section 6, Section 7, which protects life, liberty, security of the person, privacy rights, which have been interpreted into Section 8, and then equality and discrimination rights. So these are the kinds of claims that people might potentially bring against a requirement for vaccination. And in the context of children going to school, it may well be around religion or conscious rights, or potentially security of the person. Now, I think the important thing, though, is to understand is that when we think about rights, we don't have a right to everything. we think we want or don't want. For example, we can't claim a right to conscience to resist, for example, not wearing a seatbelt or a crash helmet, or these kinds of things. And so the first question that a court will ask is there a right engaged? Is this a real potential infringement of a charter right? But even if one is successful in that claim, then the next question is a government able to defend the taking away, if you wish, of this right in the context of what is going on? So in the context of a pandemic, is it reasonable? Is it proportionate to require children to be vaccinated? So here are, some perhaps just general principles to think that I think are helpful to think about how the courts approach the question of precaution. So requirements for vaccination or lockdowns or testing and tracing or requirements for masking, whatever they may be. These are just some general principles. So the first is that the context of the pandemic itself is very important and really essential to the court's assessment of whether or not the government's actions are reasonable or proportionate. The second point is that Canadian courts so far have been quite deferential to governmental decision-making in the pandemic context, but sometimes, though, have stepped up and said governments are going too far. So, for example, they required the Quebec government to carve out exemptions for the homeless from their curfew. The third general point is that the evidentiary burden will fall to the government at a certain point in a charter analysis. And so the government must be able to point to at least some evidence justifying the measure. And the law will be quite responsive to the science and the evolving science. And finally, as the science evolves, courts may ask more of governments. Particularly, could the government's goal of saving lives and reducing infections have been achieved by less infringing means? So, the fact that there may be a requirement for proof of vaccination in the context of the pandemic and surging infections and so on, once that time has passed and that context has passed, then perhaps the justification for that requirement will also fade away and the courts will not uphold the government measure over time. So I think, those general principles are really important to keep in your mind when you think about whether or not, for example, a requirement for kids to be vaccinated to attend schools can be justified. So I think it's just essential to understand that governments must, from a charter perspective, they must be reflective of the evolving scientific evidence in order to successfully defend precautions that encroach on civil liberties. Okay, so in the context of childhood vaccination for COVID-19, there are some important factors that we have to keep in mind, and we've heard a little about them already, some very important insights from the two previous speakers. So if we go to the next slide, please. So these are some of the things I think that the court will consider. Again, as mentioned, the context of the pandemic itself. How urgent is it from the perspective of children themselves and larger societal needs that children be vaccinated? What is the existing evidence on the safety and efficacy of the vaccines for children? So these are all things that the court will take into account. The second thing they'll take into account is what other countries are doing. The fact that other jurisdictions, for example, California, I believe Costa Rica, have already announced plans to require vaccinations for children attending public and private schools will be relevant to the court's analysis. Another factor here will be rights to education and international commitments to rights to education. Here, the court will be reflecting on the context of school shutdowns over many months and the fact, of course, that very vulnerable children who can't be vaccinated, or even if they are vaccinated, will be potentially unable to attend school if there are many other children who aren't similarly vaccinated. And then finally, an important aspect of that is that any regime that might come to pass will have to allow for accommodations on the grounds of medical disability. So of course, children that can't be vaccinated will need to be accommodated. And I think much more difficult questions will swirl around whether or not there should be religious or conscience objections and what form they should take. And I can come back to that in Q&A if one would like. So all of this, I think, suggests that we don't really know what's on our horizon with Omicron, and we're sort of I guess we're all on tenterhooks, waiting to see and to get more evidence about what the impact that will have across Canadian provinces. But if assuming for the moment that we are not in a state of crisis right now, I imagine that the courts will want to be satisfied before they would permit a move to mandates that reasonable measures have been taken to spur voluntary vaccination rates, and that those outcomes have not been sufficient to respond to the pandemic. So some graduated policy options might flow as follows. So first, that significant efforts are taken to facilitate ease of access to vaccination in schools and support for the hesitant. So of course, the most important thing is that we make it easy and we make it available for everybody who might possibly be happy enough to be vaccinated, but find it difficult for all sorts of reasons to get out from work or wherever to take their child to be vaccinated. Secondly, that, if that is not sufficient, then the next stage would be to require proof of vaccination within schools. So to simply have that recorded, who is vaccinated and who is not. And then in the case of an outbreak, to send the unvaccinated home. And that may in of itself be quite a sufficient spur for many to get around to getting their children vaccinated because of the inconvenience of having to stay home with your children if they're out of school. The next step beyond that might be to include children and adolescents under the Vax Pass requirements that we have presently in some provinces for non-essential services. So for example, to require children to have proof of vaccination to attend restaurants, pubs, and so on. And then finally, if none of that is working sufficiently, to require proof of vaccination. If you can't provide that proof of vaccination, unless you have a medical disability that prevents you being vaccinated, then you're barred altogether from public or private school, or you have to learn at home online. And, the bigger question here will be around carve-outs for religion or conscience objections. And as I said, this I think will be the trickiest part of how this is resolved over time if we have to get to that stage. And again, I just want to caveat again, this is, the context of the pandemic is essential to how the courts will assess this. There are some more resources, materials that we've written on mandatory vaccination, vaccine passports, if you're interested at this website. So thank you very much. And I really look forward to hearing the next speaker and the conversation.
Thanks very much, Dr. Flood. Next, we have Dr. Behn Smith, who is going to speak to this question. What does the vaccination of kids against COVID-19 enable for schools and for communities?
Thank you so much, Shannon, and thank you so much to the other panelists. This is such an engaging conversation this morning. As was mentioned previously, my name's Danièle Behn-Smith. I'm Echo-Dene from Fort Nelson First Nation, and I'm French-Canadian Métis from the Red River Valley. And I'm very grateful to be calling in today from the territory of the Lekwungen peoples of the Songhees and Esquimalt nations in what's colonially known as Victoria. This conversation and this topic of COVID-19 vaccines and kids is very near and dear to my heart, both due to my role as BC's Deputy Provincial Health Officer for Indigenous Health, but also as a mom of 2 school-aged children and going through a pandemic as a family, and really seeing front and center how the pandemic has been impacting kids. Providing vaccination for school-aged children really enables them to get back to the activities that matter most with an additional layer of protection and confidence. As Dr. Allen mentioned, though children were underrepresented in COVID-19 cases in the first 3 waves of the pandemic, children under the age of 12 have been much more impacted in this last 4th wave. And that's due to the fact that they are the age group that had not been vaccinated up until recently. And also that with the gradual reopening of society, we continue to have COVID-19 transmission, and as it's an endemic virus now. Pandemics are bad for kids. It's really that simple. We were on a call the other day with one of my colleagues, Dr. John Kim, who's the Chief Medical Health Officer in Northern Health here in BC. And he just stated it so simply like that. And it resonated so deeply for those of us on the call. We've been very lucky, as Dr. Allen mentioned, that this virus tends to be quite a mild illness in the vast majority of kids, but some do go on to develop serious disease, and others can develop serious complications that may be with them for the rest of their lives. And by far, the greatest burden that children have had to bear during the pandemic is the negative impacts and the disruption to school, extracurricular activities, and social connection. We undertook quite a large survey here in BC that we've done 2 rounds. It's called the SPEAK survey. The first round, we had well over 400,000 people, citizens of BC, who participated. And we heard loud and clear from children with school, or families with school-aged children, that the COVID-19 pandemic has had really significant impacts. So we heard that approximately 3/4 reported that their children had less connection with friends. 3/4 reported that their children had experienced impaired learning. 3/4 had reported that their children were experiencing increased mental stress, and 90% of families reported that their children were spending more time in front of screens. Vaccinating children really enables our communities to continue to build confidence about sending kids to school, to sports, and to the activities that are essential to their development. As I mentioned, I have 2 daughters, Lucy, who's 9, and Maeve, who's 5, and they were amongst the first children to be vaccinated here in BC, and we were all so grateful. And when a reporter asked my older daughter why she was excited to be vaccinated, she said, because now I can go and visit my family in Fort Nelson, and I haven't seen them in so long. For us as a First Nations and Métis family, these vaccines are enabling us to reconnect with our family, with our communities, and to continue that really important work of maintaining our cultural continuity. Pandemics are bad for kids, and conversely, vaccines are good for kids because they enable kids to get back to or continue with the activities that matter most in nurturing their social, emotional, mental, physical well-being and health. Masi Cho, thank you again to the Royal Canadian Society for inviting me to participate in the panel this morning. And so grateful to be here, and I look forward to the conversation. Masi.
Thank you very much, Dr. Behn-Smith. I would again invite our audience, if anyone has any questions, you can type them into the Q&A box. I'm going to get us started off because, of course, I'm a reporter and reporters always have questions. It's what we do. I would open this to any of the panelists. This is actually one of my favorite questions to ask anyone with an area of expertise, which is just what misconceptions have you seen about children and COVID or children and the vaccines that sort of drive you a bit crazy or that you would like to correct for the public? Are there sort of things we get wrong over and over again? Anyone, please feel free to chime in.
I'm happy to jump in because we've seen over the last few months the re-emergence of concerns regarding fertility in the future. And this is really wrong because there's really no scientific basis for that. I know there were questions raised because of the data that showed changes in the menstrual cycle in women, but that has nothing to do with fertility. And in fact, the menstrual changes are not a reflection of a reproductive issue, but rather likely a manifestation of a transient change in the immune response that the body has put out secondary to the vaccine. And so it's really important to make it quite clear that the vaccines will not make children infertile in the future.
Thank you for that. I see a raised hand from Dr. Flood. Please go ahead.
Oh, thank you, Shannon. And I think one of the things that has bothered me, well, there's, probably as with everyone, quite a number of things that have bothered everybody. But when we talk about the risk to children of respectively vaccines or COVID-19, I really don't like how they're sort of segmented from society as if they're not connected to their parents and their grandparents and the society around them. I also don't like the way that the sort of focus is on healthy children as opposed to children who have compromised healthcare systems. And when we think about the risk of unvaccinated children and adults winding up needing urgent healthcare services, they are displacing not just adults, but other children. All right, other children that need care for cancer, for other kinds of treatments. They too are getting their needs subrogated as we try to deal with really, as folks have said, what has become a pandemic of the unvaccinated. So to me, I think it's really important to have this more full view of children and their connection with all of us. And I guess the other thing that probably drove everyone crazy too was this idea that children don't transmit the virus, from early on. And, it always seemed to me to be highly unlikely that was correct. And it sort of turned out to be the case. And I think that at the beginning, we all just wished this was true. Those of us with children, we just wished it to be true. And thus it was true. It was a matter of religion rather than science. So I think we have to be very careful about those kinds of things. That's my thoughts, Shannon.
Thanks very much. Dr. Behn-Smith, please go ahead. Great, thank you. Yes, I just wanted to pick up on Dr. Flood and Dr. Allen's comments as well with that idea of, I think around, imagining, or not imagining, but calculating the risks. Parents are faced with this decision and they're needing to process a lot of information to determine what they feel is best for their child. And I have no doubt in my mind that, you know, it is, and we've seen that in surveys, you know, a third of parents who were eager to be first in line to get their vaccine said, I'm not as sure for my kids if I'm gonna, you know, have them there at the first available appointment, or if I'm gonna spend a bit more time learning about the vaccines for kids. And I think there's, for me, a couple of important pieces. So one is around that idea of what risks are you calculating? And so one of the pieces of misinformation that I encounter, and it may be more of a miscalculation, is that I see parents who are focusing on the potential, the very small and rare potential of side effects with the vaccine, and not considering the potential risks of COVID-19. And as Dr. Allen mentioned, for example, myocarditis or pericarditis, likely there is more risk should your child develop COVID-19 of developing those complications than if they receive the vaccine. And I think also to Dr. Flood's comment about the transmissibility and, you know, children spreading COVID-19, certainly in the earlier waves, we didn't see that as much. Children weren't getting sick as much. We had much stricter public health measures in place. So there was less, you know, less interaction. So there wasn't a lot of children spreading the virus at that time for a lot of different reasons. Delta variant came on the scene and is way more transmissible. It spreads way more easily. And we're seeing that now. And so the other risk I just want to mention is the risk for a child's mental, emotional well-being, if they are the one who inadvertently brings COVID-19 into the home and spreads that to a vulnerable loved one. And Dr. Henry just shared with me just the other day that there was a story that she became aware of that exact scenario playing out. A young 6-year-old, you know, who was at school, developed COVID, brought it home, and shared it with a loved one who, despite being fully vaccinated, did have underlying medical conditions and did end up getting quite sick. And just how that weighed on that little child, you know, to be carrying that responsibility. So from my perspective, I think that's a piece of the narrative that hasn't really been fully fleshed out when we're talking about the benefit of these vaccines for children. But, you know, just adding in all of those additional layers of protection are so important. Thanks.
Thank you. I do have a question from the audience here. Someone has written in to say, I've heard that it is recommended to wait at least 14 days after getting another vaccine, like the flu vaccine, before getting COVID-19 vaccine. Are there any known interactions or issues for children? Would anyone like to take that question?
Yeah, I'm happy to take that. From the point of view of the science, you can actually give both vaccines, COVID as well as regular vaccines, the same day. So from the point of view of science, there's no issue. In terms of interaction, the challenge has more to do with side effects. Like if you give 2 vaccines at the same time and there's a side effect, like, you know, whatever that side effect might be, then it's unclear which vaccine caused what. And so allowing separation of 2 weeks just brings some more clarity in terms of what might be causing what. But if it were necessary to shorten that interval for practical reasons, it certainly can be done.
Thank you. I have another question. This would be directed to Dr. Flood. Just connected to what you were speaking about, can you elaborate a little more on the sort of more tricky case of religious or conscience exemptions for requiring vaccinations for school?
Sure. So on the conscience one, so there are actually very few. Well, I think no major religion has sort of come out and said that you know, they. Well, all major religions have come out in support of vaccines. So I think it would be difficult to argue, although the court is very open to claims by people that X or Y is their, fundamental religious beliefs. They don't go into it too far. And so then it would come down to a question of could the government justify a requirement for vaccination in schools, as I said, given the whole context of the pandemic. But when it comes to conscience, I think this is where we start to get into more tricky territory, because I think a lot of people think, who may be anti-vaxxers feel that it is a matter of conscience for them, that they have this very strongly held belief. But the court so far, there's very limited case law on what it is to make a claim to a right to conscience. And, they have said it has to sort of be something that really amounts to equivalent to a religious sort of that fundamental to one's worldview. It can't be just, I don't like pharmaceutical companies, or, I think the government is in cahoots with the pharmaceutical companies. That's not a matter of conscience. It really has to be something so innate and fundamental. But, if the government was to permit, as they have done in Ontario in the past, people to just make a claim that it's a matter of conscience and to not really validate that, then lots of people could run off and, swear and testify that it's a matter of conscience. I don't want to have my child vaccinated. So I suspect, again, it'll be kind of a layered thing. If we're not in a state where it's a crisis and we have a little bit more room to move, then perhaps a government would allow opt-out for conscience, maybe make it a little difficult. You have to go testify, or, as currently with childhood vaccinations in Ontario, you might have to do some education about what it is why you are hesitant or opposed to vaccination. So they could make it a little tricky to make the declaration. But perhaps they will do that first before saying, well, that hasn't worked, so we need to actually just make this a mandate that no one can opt out of on the grounds of conscience. So that's why I'm sort of trying to present it as this kind of layered sandwich. But, I think, as I said, all of my comments there were on, where we are in Ottawa and Ontario right now. We're not too bad. So if everything was to change rather drastically and radically with Omicron, then, there might be a justification for moving down that sandwich a bit more rapidly to try to protect both the kids and society as large and their right to go to school. Does that make sense? Yeah. Okay.
Thank you very much for that. I think we have collectively managed to execute a miracle in that we have ended precisely on time, which is quite amazing. I'm going to wrap here. On behalf of the Royal Society of Canada and myself and our panelists, I'd like to thank the audience. Please visit the Royal Society of Canada's website if you want more COVID-19 resources, and you can join that conversation again on Twitter. Their handle is @RSC The Academies. And if you have any additional questions after this, you can email events@rsc-src.ca. Thank you very much to our panelists today. It was quite wonderful to learn from you all. Thanks, everyone. Have a good day.
Bye. Thank you. Bye-bye. Bye.